Okay, so this lecture is on post-traumatic stress disorder. Um, I've had a lot of experience treating post-traumatic stress disorder. Um, However, there have been a lot of advances uh, over the past 5 to 10 years, including virtual reality. A lot of times when people think about PTSD, they think about uh, military service men and women, and that is accurate, but um, there are many, many people who have experienced trauma and have moved on to a diagnosis of post-traumatic stress disorder. So, of course, it is related to trauma directly, but any kind of trauma, not just military trauma. I'd like to begin by sharing a few stories. Um, so, uh, I'm pretty sure that my father had post-traumatic stress disorder. He served in World War II, saw a lot of action, and would never talk about it. There have been generational changes in the way people react to PTSD. They did not have the diagnosis PTSD when he was uh, experiencing that trauma. Back then, they would call it being shell-shocked or something like that, but he wanted to be career military. He never reported any emotional problems or psychological issues. He believed that would most likely have hurt his chances of moving up that ladder and being promoted. So a lot of people who want to remain in the military do not report emotional stressors or issues. They don't want that on their record. People who come back from conflict don't often talk about it. Their families know something is going on with them. They're not sure exactly what. They begin to self-medicate. Um, I know at one point my father drank a lot of alcohol. I believe he was an alcoholic, but I also believe it was self-medication. Um, I remember being a child and going into my parents' bedroom and jumping on the bed while he was still asleep, and he threw me across the room. And that was just a reaction to being startled. I always woke him up from a distance after that, and gently. Um, the uh, the thing is, later in life, I think that had an influence on me, and so I got a lot of extra training to work with the Red Cross, and now I do two things with the Red Cross. Um, I work with the Yellow Ribbon program, and the Red Cross's program within that broader context is called Reconnections. And when deployed military come back from serving overseas, the Red Cross sends teams who have been trained in reconnecting them with their families. And so they're usually sent to a resort, they meet their families. part of the time is having fun with their families. But the other part, they work with Red Cross personnel. They all have to be LPC, most are at the doctoral level, and they all have to go through training. So they have to go through all of the basic Red Cross training, then they have to go through the Red Cross mental health training, and then they have to go through the reconnections training. And but we bring them together. Sometimes we bring them together in groups. The military personnel talk about what it's like coming back, talk about their stresses, ways they can cope better. Then we bring them in groups with their families, and we talk about struggles and how to overcome them. We also do some screening. We might need to refer for further services. We don't keep a record in their files about that. We don't want to hinder them or limit them from sharing in any way, but we do make recommendations to the personnel, and we find them help if they need it. It's been a meaningful experience for me, and I hope them as well. We've added on a new module for that just for the children of military families, and I think that is very valuable. Another thing I do for the Red Cross is I'm on a team of mental health workers that is usually called to a scene with first responders where there's been a death or a tragedy. This was difficult for me at first, but I find it extremely meaningful now. I first worked with victims of the LA Fitness shooting, and then I worked with victims of the Tree of Life shooting, and we were there immediately after those tragedies to be with those individuals, those victims, and their families. A lot of times we're there for extended periods of time. So, for instance, the LA Fitness tragedy, we were there virtually all night at the hospital with the families because many of the individuals were in surgery, and we wanted to be with the families until that was resolved. And every situation is different. There are many opportunities, those are just local ones, I guess I started that with 9/11, started that process, and I responded locally to individuals who were worried about loved ones in New York City on 9/11. I do travel quite a bit with the Yellow Ribbon program and Reconnections, but I have not had the opportunity to travel to those traumatic emergencies, just because I have extremely young children. Now, the other things I'd like to share while I'm talking about those Red Cross experiences, we want to help people as soon as possible so that we might maybe prevent a little post-traumatic stress in their future. So the earlier you can get help, the more successful it is. One thing that many people did not realize is that a lot of the first responders, even though they did not experience the trauma, did experience some post-traumatic stress because they were the first people on the scene. They were witness to tragedy. They had to deal with whatever the negative trauma was. It might have still been going on. So there is a secondary stress for first responders, whether it be firefighters or police officers or military or nurses and doctors, whoever appeared on that scene, paramedics, first, usually experienced quite a bit of stress, and they witnessed a lot of negative things. They were also able to help quite a bit as well. But it's only after that adrenaline surge has calmed a little bit that they need debriefed and processed emotionally. So we use critical incident stress debriefing, CISD, and we usually try to find a time when they're no longer needed in the emergency. We bring them together. We allow them to process what occurred together as a group. We talk about what is a normal emotional and physical response to trauma and stress. So we try to normalize a lot of what they're experiencing. We're not negating it, but we want to let them know what is, a normal response to tragedy. And we also want to let them know what is not, so that if they are, experiencing post-traumatic stress symptomology, that they can seek help over the next week or months. Many times we will call them a week later and then a month later just to check in on them. One of the things I did after 9/11 was I would check in regularly with first responders. So I would call New York, or with Red Cross workers and see how they were doing. My good friend Mark Lepore is able to travel quite a bit more than me, and he's responded to the California wildfires, the Hurricane Katrina, and a lot of other national events like that. I have found that I don't have to solve all of their problems. Sometimes they are unsolvable. If somebody has lost a loved one, I can't fix that, but I can be there for them. I can be present for them. I can listen to them. I can use some basic psychological interventions. I can help them if they are experiencing a lot of traumatic stress to process that. I can help the first responders process their traumatic stress. Um, so those are my Red Cross examples. Um, Another example I'd like to share with you is I've experienced uh, a lot of clients who may have stopped taking their medication, who might have uh, whatever diagnosis, but um, they've had issues with police and authorities. I've learned that some police are trained in de-escalation and dealing with people with mental health issues, and they do an excellent job. Some areas, they need more training. And it really depends on where that police department is, whether they've received extensive training or not. I had one client stop taking medication and begin to have a psychotic break. The police were called, and they called me as well. When I called back, they had already responded with extreme prejudice, and my client was shot and died. If they had been trained in de-escalation, if I was able to talk with my client, knowing my client, I feel sure that that could have been de-escalated and he could have survived. So following up on that, one of the things that I was able to do with students from California was we went on a mission trip to Belize, and we were able to train all of the future police officers at the Belize Police Academy in all kinds of emotional regulation and de-escalation. Everything from talking to people who were suicidal to de-escalating a stressful situation. And they were very happy to have those 2 full days of training. And that's asking a lot. They have a lot to cover in that school. But they felt that was important. The other thing I wanted to do was share a personal example of, I guess, one of my own traumas, and how that manifested. So sometimes I give this example in theories as well when we talk about EMDR. So if you heard it, just go with it. All right, so when I was teaching theories one year, I knew that a previous student of mine had been trained in EMDR. Back then, EMDR was pretty new. That's how old this is. But so I invited her to come and teach EMDR in my theories class. And she did a great job, and but then she wanted to demonstrate it. And of course, she asked for a volunteer, and no student would volunteer. And so she asked, well, do I have anything? Could I volunteer? And I thought about it, and I thought, all right, I have something that might be a little traumatic. So we sat down and we did this EMDR. I did not buy into EMDR at the time. It takes a lot for me to buy into some newfangled theory, but I buy into it now. So I had to think of a time where I might have experienced some trauma. So I was 19. I guess I was 20, and I was traveling through India. I was on a train ride that lasted 3 days. And, people are riding on the roof of trains. People are hanging out the windows. There's no glass. They keep the doors open to keep it cool. And I was sharing a compartment with an Indian family, man, wife, and son, who was about 10. And I did not speak their language. They did not speak English. But uh, we shared food. We played cards together. I played games with the little kid, and we had a great time. We really got to know each other uh, without knowing one another's language. Now, at night, if you have a compartment on the train, the seats fold down and you can lay down and go to sleep. The second night, we were in central India. There had been a lot of social unrest, and around 2 or 3 o'clock in the morning, we stopped in an area where there had been a lot of conflict, a lot of soldiers who had experienced that, because they called the military to suppress a lot of the riots, and a lot of the military got on the train. Well, back then, there were not a lot of white males, military age. Back then, I was kind of fit. I was wearing military fatigues, had a military backpack, and they did not understand what was going on. They dragged me out of the bunk, held some AKs to my head, and started screaming at me. It escalated very quickly because they already had a lot of adrenaline. They had already experienced conflict for hours. They felt threatened prior by violent people. And I was an unexpected variable. It kept escalating, and I was starting to get worried. I was saying a little prayer, and but I wasn't sure what to do, because once again, I did not have their language, and there are dozens of languages throughout India. You can't just learn one. When it became very stressful, the man who was with the family stood up very slowly, and the soldier's rifle was only about a foot away from my face. And there were multiple soldiers, but he slowly stood in between me and the soldier's rifle and started talking very calmly. And he gradually pointed to the bunk, and I laid back down on the bunk. Everything had de-escalated. The soldier laid down next to me and immediately fell asleep. Needless to say, I was awake for the rest of the night. One of the things I ask myself is, what if I was on a train in New York City or someplace, and maybe somebody who had trouble with language was in a similar situation that I was? Would I stand up, especially if I was with my family, and intervene? I don't really know the answer to that, but I'm hoping I would. But every now and then, that memory would pop up in my mind. I didn't know what to do with it, and I would experience a little anxiety. I would not call it post-traumatic stress disorder. I don't think it was that serious, but it was recurring, and I never knew when it would recur. Sometimes it was a smell, sometimes something would trigger that memory. So we did EMDR, And so it has to do with eye movement. I believe, some people think it's like self-hypnosis. I believe that when we sleep, we process in our minds when we dream what happened during the day. They've also found that when we sleep during REM cycle, fluid comes from our spinal column and enters our brains and washes our brains. And sometimes, if we've experienced a trauma and we don't sleep properly, we don't enter REM stage, and those memories are not processed in the same way, so they haunt us. EMDR uses eye movement, relaxation, anxiety scales, all and processing of the traumatic event. I thanked the student for her role play and demonstration, and then I forgot about it. Months later, I thought about it, and I'm like, I have not thought about that traumatic event in months. So I was kind of sold on EMDR. You do have to get special training for EMDR. I would combine it with other therapy. I would not just do EMDR. I would combine it with other talk therapies. Many times it is combined with medication. I would always recommend non-addictive medication like a beta blocker, because that can help rapid heartbeat, adrenaline surges when we wake up unexpectedly. It's non-addictive. It doesn't create a high. It does create a calming effect because it regulates heart rhythm and blood pressure. So I would highly recommend that over like a benzodiazepine. But sometimes people need to take both. I want to give you one other example. With children, I use a lot of play therapy. When I was starting a private practice right after my master's degree, there were very few therapists in the small town where I lived, and I was the only male therapist in our practice, and there was really nobody to see children, especially male children, who had experienced abuse, sexual abuse, emotional abuse, neglect, trauma. And so I got extra training in that just because the community needed that. It was not something that I had worked to go into. It was not an interest when I went through my degree. So with children, I do use quite a bit of play therapy, expressive arts therapy, teenagers, combination of expressive arts therapy and different theories with talk therapy, and adults. I really try to figure out what's best for that individual. A lot of people go into that type of counseling that they use the same thing over and over again. But I think it's important to cater the therapy for the individual and their trauma. But my final example is a very young girl, 10 years old. She was held hostage at gunpoint, and she was severely traumatized. She thought she was going to die. And of course, there was also a lot of violence because police had to rescue her. She did not feel safe or trusting at all anywhere. But play therapy, it took 4 sessions for her to enter the play therapy room, the playroom. And I would sit in the room and I would do puppets or artwork or whatever. And she would sit outside the door and watch me. And eventually she came in the playroom. But I did not force her. I don't require clients to do anything that they don't want to do, of course, even children. So I don't say, please come in. I let them do this at their own time. I do want to mention that we have 2 special topics classes. We have a class on trauma, which includes abuse. And there are so many different varieties of trauma, traumatic experiences, different theories to address those. I know that Jeff Samid's wife used to be the director of the Blackburn Center. They have an entire 8-week training program for anybody who wants to volunteer there. I think most centers for women's issues, abuse, children's issues have their own training program. Each one's a little different, but they all have to cover specific things that are mandated. So there's that class if you're interested in trauma specifically. And we also have field education in places, settings that address trauma. And the other class is expressive arts therapy. And you kind of get your feet wet in all of the different types of expressive arts therapy. I would recommend, if you want to go into trauma treatment, that EMDR is fairly expensive. And you have to go to 3 different levels of training, but I think it's worth it in combination with other therapies. Some people, I do not agree with doing EMDR by itself. I think the traumatic experience has to be processed when the client is ready. So let's look at our notes really quick. I'm sorry those examples took a little while, but maybe you found them meaningful, helpful. So differential diagnosis: if the anxiety-linked symptoms last for at least 3 days, but less than 1 month, it fits under the diagnosis of acute stress disorder. If the symptoms last for a period longer than 1 month, it fits under the criteria of post-traumatic stress disorder. However, in addition to the length of time criteria, the onset of symptoms may begin much later, perhaps even years later for post-traumatic stress. There might be a trigger, there may be a new life stressor that brings about this symptoms. Symptoms for acute stress disorder fall into 5 clusters, overlapping 4 essential symptoms of PTSD. 5th cluster includes dissociative symptoms. 5 symptom clusters are intrusive, avoidance, dissociative, negative mood, and arousal. Etiology: 5% of the total population experience one of the disorders in any given year. That's a lot of people. 7.8% will suffer from one in their lifetime. Another 6 to 15% will experience some of the symptoms without a diagnosis. 20% of women exposed to serious traumas develop symptoms compared to 8% of men exposed. And I believe that is usually a result of various forms of abuse, which are extremely traumatic. Both men and women can be abused, but the percentage of women is much higher. The stressful event by itself does not fully explain the cause of the disorder. Individuals may experience similar situations and have very different reactions. So two people can experience the same trauma but react totally differently. Resilience training. Why are some people more resilient from trauma than others? How can we help people to become more resilient? Biologists have gathered information that traumatic events may actually trigger changes in the brain and body, particularly in the activity of neurotransmitters and hormones, which may lead to the disorders. I know I talked with a physician, and they say sometimes when people experience things that raise adrenaline, if they've experienced a previous trauma, that adrenaline can kind of get stuck and it'd be hard to bring back down. Excuse me. When laboratory subjects experienced stressful stimuli, they showed a rise in norepinephrine activity, particularly in brain regions such as the locus coeruleus, hippocampus, amygdala, and hypothalamus. In studies of twins who experienced combat, if one twin displayed symptoms of stress disorder, the other twin was also more likely to display symptoms. Stressful childhood experiences, such as early divorce of parents, poverty, may contribute to the disorder. Treatment. Rape victims should also receive specific medical attention. Between 4 to 30% of victims develop a sexually transmitted disease. 5% become pregnant. A national survey has revealed that 60% of rape victims received no pregnancy testing or prophylaxis, and 73% received no information or testing for HIV. Males who have been victims of sexual abuse also need similar services and therapeutic care, including children. One survey suggests that post-traumatic symptoms lasted an average of 3 years with treatment, 5.5 years without treatment. Treatments vary depending on the traumatic event. EMDR, eye movement desensitization and reprocessing, has had some success. Group therapy and individual therapy may be used in combination with medication. The last thing I want to talk about is I've worked with a lot of military who have experienced post-traumatic stress disorder while they were deployed, and they were sent to a VA hospital, and the VA hospitals are doing a good job dealing with post-traumatic stress disorder, but there's a problem. So they use EMDR, they use group counseling, they process the trauma, and if it's a larger hospital, they use virtual reality for desensitization. All of that seems to work. Here's the problem. Many times after a post-traumatic stress disorder experience or event or trauma, after all of this healing occurs, they send them back into active duty, into conflict. Now, if you have multiple traumas, then it's much more difficult to deal with. And then they usually result in use of medication over a long period of time. But that that should be avoided. There should be no redeployment after PTSD. I guess it's a result of shortages. I don't know. But the purpose of desensitization and processing this is to help the individual to heal, not to redeploy. So I think they have that a little mixed up. The other thing I want to mention is that there is an extremely high suicide rate with veterans or people still in the military. So always screen for suicidal ideation. We could have an entire course just on abuse, trauma, PTSD. But I think this is enough for the DSM course, and I hope you found this helpful.